Hi, my name is Pritham Raj. I'm a board-certified internist, psychiatrist, and also have a certification in psychosomatic medicine. I am a clinician educator at Oregon Health and Science University, where I serve as the medical director of the internal medicine practice. Memory disorders are a common complaint. So, patient comes in complaining of difficulty with recent memory, and thoughts start to drift to a differential diagnosis of whether this is prodromal Alzheimer's dementia, whether this is an iatrogenic complication of medication therapy. So the differential gets very broad very quickly, but we want to have a systematic way of assessing for cognitive changes in our patients. And so I'm a big fan of rating scales, and I teach all of my residents at OHSU the importance of rating scales, whether it be for depression, anxiety, and certainly for cognition. And we tend to use a lot of scales such as the SLUMS or the MoCA or the Folstein Mini Mental State Exam to get a snapshot of cognition. And so once we've done that and established that, say, there is a deficit in memory per se, or perhaps there is an executive functioning deficit that we've noticed and a patient has strong cerebrovascular or coronary atherosclerotic problems on their problem list, then we start to kind of hone down on whether we're looking at vascular risk factors or prodromal Alzheimer's type picture or other cognitive impairment kinds of issues. Then once we've established that there is a problem, then we start to look at, well, what is the exact etiology, and then that's where infections are often a culprit in older patients who may have a touch of delirium or even delirium superimposed on early cognitive problems. We call that beclouded dementia. If there are no real identifiable problems, then we also want to entertain pseudo dementia. Right? Pseudo dementia is where mood states or anxiety states can mimic cognitive changes, and we want to look at that and make sure we've screened for that. And then I often get asked, well then, okay, we've diagnosed mild cognitive impairment, we've diagnosed maybe some delirium, what do we do next? So the treatment phase is really, it boils down to what I spend 80% of my time, I think, as an internist doing, which gets back to diet optimization, activity level modification. Notice I didn't say exercise, but activity level modification, and then other kinds of things which pharmacal therapy can be part of. So I was an active researcher in the Cache County Memory Study that was based in Utah, and it was a multi academic center based study. And what we found in that was, in some cases, in observational data, some nutrition and nutrients were impactful in preserving cognition. So I'm thinking of one particular example where one of our observational studies showed that the combination of vitamin E and C together was very helpful, and you think about the antioxidant properties, etc., that were helpful in slowing down the progression of early mild cognitive impairment, the prodrome to Alzheimer's. Then it gets to activity level. Is the patient active? There is abundance of data where activity level correlates with health in general, and certainly in cognitive protection. And even there was a nice article talking about the speed of gait, of how fast somebody walks is even a predictor of how they will do at 5 and 10 year intervals, especially as we get older. So I focus on getting my activity level, and I talk about wearing a pedometer. I've done that myself at our home institution. We're big on focusing on activity level, and that's just walking. Patients don't like to sometimes hear the word exercise because they often think about, well, I have to go to a gym or get expensive equipment, but we're talking about simple walking, and walking quickly, to the tune of about 1.5 miles per day is the recommended amount of activity level. So not really focusing on maximal heart rates or anything like that. I just want my patients, especially with early cognitive changes, to walk about 1.5 miles at a relatively easy pace, which would be about a 20-minute mile. That's the kind of thing. And wearing a pedometer helps to sometimes raise awareness on that. And then a lot of controversy on things like brain teasers. I clinically have seen a lot of benefit, and some experts in the field have actually reported that there may be merits that were not really fully studied in that Nature article, which seemed to discount the benefits of brain teasers. But that I still think that there's some merit to advising our patients to exercise their brain, if you will. And then we get to pharmacotherapy. If it's in an early, mild, moderate Alzheimer's dementia state, that's when we talk about cholinesterase inhibitors. They have not been the panacea that we were hoping for on those fronts, but it is a treatment option. Again, if we are practicing shared decision making, that's probably one thing we want to talk about. And as things progress to moderate to severe Alzheimer's dementia, then Namenda or memantine in combination with cholinesterase inhibitor is probably the most compelling data, but there is some monotherapy data there as well for that. But again, drugs right now, not as important as I think lifestyle modification